Welcome to the Deep Dive, where we cut through the noise to deliver clear, actionable insights. Today, we're tackling a topic that might genuinely surprise you in how common it is, and also its complexities: lip cancer. We've gone through the research you provided, and basically our mission today is to pull out those essential aha moments. We want to leave you really well informed and hopefully with a fresh perspective on this.
Yeah, it's a really fascinating area, often overlooked, I think. But it presents this unique sort of paradox, doesn't it? It's a cancer that's highly visible, usually easy to diagnose, but it can still behave aggressively. And it demands some really intricate surgical solutions, some of the most complex in head and neck medicine, actually. So we'll look at its surprising prevalence, delve into how even tiny anatomical details completely change how it spreads, and really reveal why early detection here isn't just important often, it's the entire battle.
Okay, let's unpack this then. When we talk about lip cancer, what exactly are we dealing with? And what makes it different from, say, other oral cancers?
Well, you might be surprised. Lip cancer is actually one of the most common cancers of the head and neck region, which seems counterintuitive, maybe. But it's often also one of the most easily diagnosed, so it typically carries a good prognosis. In the U.S., we see around 4,300 new cases each year. That leads to about 150 deaths. Now, what's fascinating here is that while it often has a good outcome, treatable, it can behave aggressively in up to maybe 15% of patients, leading to recurrence or even mortality. So that duality, generally good prognosis, but potential for serious aggression, that's one of its unique things.
Okay, so primarily what type of cancer are we talking about, and where on the lip does it usually, show up?
Right. The vast majority, almost all cases, are what we call squamous cell carcinoma. That's a type of cancer starting in the flat scale-like cells on the surface. Your skin has them, your lip lining. A much, much rarer type is basal cell carcinoma, also a common skin cancer, but only about 1% of lip cancers. Very rare there. And location, the lower lip. By far, we're talking 88% to maybe 98% of cases. Only a small percentage, maybe 2 to 7%, occur on the upper lip, and even fewer, 2 to 4%, right at the oral commissures, the corners of the mouth. And this distinction is really key because lip cancer, especially on the vermilion, the red part, it actually behaves more like skin cancer. It's different from cancer starting deeper inside the mouth.
That's interesting, acting more like skin cancer.
Hmm.
So who's most at risk then? And does it vary a lot geographically
Mm-hmm.
around the world?
Oh, absolutely. Huge variations globally, which points straight towards environmental factors, right? Sun exposure, mostly. In some regions, it can be up to 30% of all malignant oral cavity tumors, 30%. So in the U.S. Sunbelt region,
Yeah.
the incidence hits 12.7 cases per 100,000 people. That makes it the most common oral cavity cancer there, only behind skin cancer of the head and neck generally. Continental Europe, Australia, also high incidences, 13.5 cases per 100,000 respectively. But then you look at parts of Asia and it's relatively uncommon, so it's quite a patchwork.
That is a stark contrast. Wow. But given that global variation, does the data maybe hide other factors like socioeconomic things, cultural habits? Less obvious than just sun. What about the trends here in the U.S. specifically? Demographics.
Yeah, you're right to look deeper. While the overall U.S. incidence is now 1.0 per 100,000, which is actually a big improvement, about 58% better than prior data, probably due to awareness, sun protection, things like that, certain disparities definitely persist. And they hint at complex interactions, lifestyle, biology, Men are affected at much higher rates than women. It's about 1.85 per 100,000 males versus only 0.34 for females. Big gap. Age is also a huge factor, nearly 70% of new cases, diagnosed in adults aged 60 or older. Though occasionally you do see it in people younger than 30. It's rare, but it happens.
Those gaps are really striking. Gender and age. So does that mean biological traits like, say, skin type are also a major piece of this puzzle?
Yes, absolutely pivotal. Lip cancer mainly affects people with fair skin complexions. The prevalence is at least 10 times higher in white individuals compared to those with darker skin, and it's extremely rare among Black individuals. This is pretty widely believed to be due to the protective pigment, melanin, in the vermilion. That's the red part of your lip. In darker-skinned individuals, it basically offers natural protection from sun damage, like a built-in sunscreen, essentially.
That's a powerful natural defense.
Okay.
Okay. So we know who gets it, where it happens geographically. Let's get to the crucial why. What exactly causes this? Is the full picture understood now, or are there still missing pieces?
Right, the etiology, the causes. And it's still, well, incompletely understood, is the scientific way to put it. Direct cause and effect hasn't been definitively proven for all the suspected factors, but several factors are very strongly associated, and understanding those is absolutely key for prevention.
Okay, so what are the strongest links, the things the research really points to?
Sun exposure, that's the overwhelming major one. Consistently cited, study after study, the primary culprit. About a third of patients diagnosed with lip cancer have outdoor jobs. That really highlights the connection. And the lower lip just sticks out more, right? It's much more susceptible to sun than the upper lip, which clearly explains why the incidence is so much higher there. It just gets more UV radiation, simple as that.
It makes perfect sense for sun.
Yeah.
Okay, but what about things like tobacco or HPV? We hear those linked all the time to other oral cancers, head and neck cancers.
Yeah.
Do they play a similar role here?
Here's where it gets really interesting. And a bit nuanced, actually. Tobacco, yes, especially pipe smoking, has often been linked historically. You'll see that in older literature. However, some studies, even going back to 1984 and then later controlled studies, they've actually concluded there's insufficient proof for tobacco as a primary cause, a primary etiologic factor in lip cancer specifically, or no statistically significant relationship. Now, alcohol and tobacco. Undeniably strong links to oral cancers inside the mouth and oropharyngeal carcinomas back in the mouth, throat. But their influence specifically on lip carcinoma seems limited. Cigar and pipe smoking probably account for only a small fraction of cases today.
Wow. Okay, so the big takeaway is we can't just lump all oral cancers together. Same risk factors don't apply across the board. It's a critical reminder that even within the mouth, cancer is, well, it's a collection of different diseases, right? Each with its own causes. That's genuinely surprising about tobacco and HPV not being the main drivers here. It makes you wonder if our standard understanding needs a big asterisk for lips. So beyond sun, what else might be involved? What else should listeners know about?
You've hit a crucial point about specificity, absolutely. And regarding HPV, its role is still controversial for lip squamous carcinomas. Yes, chronic HPV is reported in some skin squamous cell cases, especially in immunosuppressed patients. But one study in people not immunosuppressed found HPV in 30% of normal lip samples, but only 18% in those with lip squamous cell carcinoma. So that suggests no clear relationship in that group anyway. Its impact seems less certain for lips compared to its established role elsewhere in the head and neck. Beyond sun, though, yeah, a number of other things have been associated. Things like thermal injury, think chronic burns from hot liquids, repeated lip trauma, poor oral hygiene, exposure to certain chemicals, mechanical irritation, like from dentures maybe, chronic infections, and then immunosuppression, a weakened immune system. That's a very significant risk factor. For instance, renal transplant patients, they're on strong drugs to suppress their immune system. They've been reported to have a 30-fold increased risk of developing lip cancer, and they might get it younger, have higher recurrence rates too. It just dramatically shows how critical a healthy immune system is in keeping these cancers in check.
Okay, so definitely multiple factors contributing. Once those cells turn cancerous, though, the next critical thing is anatomy, right? How is lip cancer actually defined medically? And crucially, how does its exact spot on the lip affect how it might spread?
That's a perfect segue. The official definition from the American Joint Committee on Cancer, they define the lip as beginning at the junction of the vermilion border. That's that distinct red line where your lip color meets your regular skin, and including only the vermilion surface or that portion of the lip that comes into contact with the opposing lip. So it specifically excludes cancers starting on the adjacent skin outside that border or on the inside lining, the inner labial mucosa. It focuses purely on that unique outer red surface. And this precise definition, it's crucial for accurate staging and treatment planning.
That's a very specific boundary line.
Okay.
So does the exact location within that boundary affect how it spreads? That seems like a really fine detail.
Oh, absolutely. It's a critical anatomical point with direct implications for strategy. So, the lower lip, embryologically, it forms from the fusion of two mandibular processes. Because of how it forms and drains, it has an increased risk for metastasis that spread to lymph nodes on the opposite side of the neck, the contralateral side, especially for lesions near the midline. Lymph drainage there primarily goes to the submental and submandibular nodes under your chin, under your jaw. Now, contrast that with the upper lip. It forms differently, involving a central median nasal process. This means metastasis to the contralateral neck, the opposite side, is exceedingly rare from the upper lip. However, the upper lip generally has a higher rate of regional spread overall, and it sometimes spreads to the ipsilateral same-side preauricular or infraauricular parotid lymph nodes, which are up near your ear. So yeah, every millimeter of that lip, it's specific lymphatic connections. It's like a unique roadmap for potential spread.
Wow. It's like knowing all the secret tunnels out of a castle, like you said before. Understanding those different paths must completely change how you approach diagnosis and treatment then.
It absolutely does. Which brings us to staging. It's crucial, and it's pretty similar to how we stage other oral cavity tumors. We use the TNM system. T for tumor size, N for node involvement, M for distant metastasis. So, for example, small tumors less than 2 centimeters are stage T1. Really large invasive tumors going into deep tissues, bones, skin, those are T4. And here's a really insidious detail we have to consider. Nerve invasion. Some cancers, including squamous cell, can be neurotropic. They like to travel along nerves, almost like using them as hidden highways. So if a patient starts complaining about new numbness or maybe a weird tingling sensation, say along the inferior alveolar nerve in the jaw, that's a critical red flag. It means the cancer might be spreading in a way we can't easily see just by looking. And that definitely warrants further scans, radiographic evaluation.
Given how visible the lip is, though, I imagine early diagnosis is pretty feasible, right? It's not exactly hidden away.
Precisely. Yeah, absolutely. Carcinomas of the lip often pop up on a highly visible, constantly exposed part of the body, which makes early diagnosis not just possible, but frankly, vital for the best outcomes. They typically look like an exophytic lesion, meaning it grows outward, or maybe an ulcerated one, like an open sore, usually right there on the vermilion border. Sometimes, especially with well-differentiated types, you might see hyperkeratosis or leukoplakia. Those are sort of thickened white patches. Basically, any suspicious spot on a lip that doesn't heal quickly. It should prompt an incisional biopsy, taking a small tissue sample for the lab. And that should happen without delay.
Okay, so once it's diagnosed, what are the main ways to treat it? Is it always surgery, or are there other options on the table?
The ultimate goal, always, is long-term control of the cancer, right? But you also want to preserve the lip's function and appearance as much as humanly possible. Now, for small tumors, T1s maybe, they can often be controlled equally well with surgery or radiation. Both are options. But surgery is generally quicker. It maintains the blood supply and the soft tissue better, and often it results in less aesthetic or functional impairment down the line. So for those reasons, surgery tends to be the most common treatment chosen for lip carcinoma, really of any size, and it's particularly favored for the larger T3 and T4 tumors.
How precise does that surgery need to be? I mean, you want to get it all, but it's the lip. Very visible, very functional.
Yeah, surgical margins are absolutely critical. There are specific guidelines. To be confident you've removed all the cancer cells, the recommendation is a minimum margin of 8 to 10 millimeters of normal tissue around a larger lip cancer. For smaller cancers, say under 1 centimeter, you might get away with slightly smaller margins, maybe 5 millimeters. But that precision, getting clear margins, is paramount for success.
Can you walk us through some of the different surgical options, depending on how extensive it is? It sounds like it could range from something fairly minor to something quite involved, especially thinking about fixing it afterwards.
Certainly. So for precancerous conditions like that leukoplakia we mentioned or carcinoma in situ where the cancer cells haven't spread yet, a lip shave or vermilionectomy is often ideal, basically removing part or all of the red vermilion surface. Now, for invasive lesions, you need a full thickness excision, removing the whole depth of the lip tissue in that area, often done in a V shape or a W shape or maybe a shield shape. If the defect isn't too large, say less than a third of the lip, those V and W shapes can often be closed primarily, just stitched back together quite simply. But more aggressive resections are needed for larger tumors, T3 or bigger, or if there's nerve invasion, or if it involves the jawbone, the mandible, that might require removing part of the bone itself.
In the reconstruction part, that must be incredibly delicate, given how much we use our lips for talking, eating, expressions.
It is indeed. Yeah, reestablishing function and appearance is paramount. It's hugely important for quality of life. A key element is always reconstituting the orbicularis oris muscle. That's the circular muscle that lets your lips pucker and move properly. So for those vermilion defects after a lip shave, we often use labial mucosal advancement flaps. That's basically moving healthy tissue from the inside of the mouth forward to cover the defect. For those full thickness excisions, up to maybe 1/3 of the lip's length. Primary closure, stitching it directly, often works well with a V-shaped design, but you have to be meticulous. Careful, multi-layered closure of the muscle, then the skin.
Okay, but what happens if a larger portion needs to be removed, more than a third? That sounds like it would require much more complex solutions to rebuild the lip.
Exactly. If defects exceed about 1/3 of the lip, the challenge really shifts. It's not just removing cancer, it's rebuilding a functional, aesthetic lip. We move beyond simple closures to more intricate reconstructive techniques. It gets quite complex. This often means borrowing tissue, sometimes from the adjacent cheek, or even taking a section from the opposite lip, the healthy lip, in a carefully staged procedure. These often involve keeping its blood supply intact through a little stalk, a vascular pedicle, which gets divided later once the flap has healed in. The Abbe-Estlander flap is a classic example. Then there are flaps like the Karapanzik flap, which is excellent for larger lower lip defects because it cleverly preserves the nerves and blood vessels, maintaining a functional lip sphincter. For complete lower lip removal, techniques like the modified Bernard flap use tissue moved in from the lateral cheeks, and for the most massive defects, maybe involving the whole lip and surrounding structures, surgeons might need to use tissue from a distant part of the body, like the forearm. That's called a free flap. They meticulously reconnect tiny blood vessels and nerves under a microscope. Radial forearm free flap is one type. The goal is always the same: restore function, speaking, eating, continence, expression, and achieve the best cosmetic result possible. These are really sophisticated procedures.
Wow, that's incredible surgical skill involved there. What about treating the lymph nodes in the neck? Is that always part of the plan, even if the cancer hasn't visibly spread there yet?
Good question. For early stage lip cancers, stages I and II typically, the elective treatment of the neck lymph nodes, the cervical nodes, is generally not needed because the risk of occult metastasis, that's microscopic spread you can't detect yet, is relatively low for these early ones. However, for advanced disease, stage 3 and 4, elective neck dissection is usually recommended. That means surgically removing lymph nodes in levels I through 3 of the neck, even if no nodes feel enlarged. And that's because the rate of microscopic metastasis is actually quite high in those advanced stages. Now, if nodes are clinically apparent, if you can feel them or see them on scans, then radiation or combined therapy surgery plus radiation is typically used.
Okay, so with all these advanced treatments, surgery, reconstruction, radiation, what are the overall outcomes for lip cancer patients? It sounds like there's definitely a lot of hope, especially if it's caught early.
Precisely. There absolutely is. The cure rate for those early T1 and T2 lip cancers, provided there's no regional metastasis, it's quite high. Over 90% actually, with either surgery or radiation. The overall 5-year determinate survival that's looking at survival specifically from the cancer, excluding other causes of death, is around 80%. And what's really encouraging, generally speaking, is that lip cancers tend to have a more favorable prognosis than most other head and neck cancers.
But are there factors that make the prognosis, well, less favorable, even with treatment?
Yes, unfortunately, several factors can negatively impact the outcome. If the cancer involves the oral commissure, the corner of the mouth, that's considered more aggressive. 5-year cure rates there can drop significantly, maybe 34% to 50%. Tumors larger than 2 centimeters. Cure rates generally fall below 80%. And those that invade the jawbone, the mandible, cure rates can be less than 50%. Interestingly, the main reason treatment fails is usually local recurrence, the cancer coming back right where it started. It's less often due to spread to the neck nodes initially. Other adverse factors include a poor histologic grade, meaning the cells look very abnormal under the microscope. Also, tumor thickness greater than 6 millimeters, and definite invasion into muscle or along nerves. Those are all bad signs.
And how much does that lymph node involvement impact survival? We talked about spread earlier.
Yeah, the presence of cervical lymph node metastasis significantly worsens the prognosis. The average 5-year survival for patients who do have cervical meds from lip cancer drops to about 50%. It can range maybe from 29% up to 68%, depending on the extent. And recurrence rates in the neck after treatment can be worryingly high, maybe 40% for N1 disease, even up to 100% for extensive N3 disease. It makes it much harder to cure. And one more thing worth noting. There's an estimated 20% risk of developing a new second primary lip cancer within 10 years after successfully treating the first one, which really highlights the need for lifelong vigilance and, of course, ongoing sun protection.
Okay, so to sort of bring this all together, we've learned lip cancer is actually quite common among head and neck cancers. Lower lip is the main spot. Sun exposure is the key etiological factor, the main cause. Often has a good prognosis if caught early, thankfully, but advanced cases, they require incredibly complex, precise surgery and reconstruction, and ongoing monitoring is vital.
Exactly. And ultimately, what this deep dive really underscores, I think, is that the very visibility of lip cancer is, well, it's its greatest risk because of sun exposure. and also its greatest gift, because it does often allow for early detection. You can see it, that stark difference in prognosis between early and advanced stages. And the sheer ingenuity needed for these complex reconstructions, it just powerfully drives home the importance of vigilance, of seeking professional evaluation for any persistent lip sore or lesion that doesn't heal quickly. For you, the listener, this isn't just abstract medical info, it's a potent reminder. Sometimes the most dangerous things are literally right there on your face. And knowing what to look for, paying attention, that can genuinely be life-saving.